Hello guys, welcome to ARBORVITAENXT. Today we are going to discuss about thromboelastography. Recently in NEETPG and in INICET, both exams, this topic has been asked. So I thought we should discuss about this. So basically this is the machine which is known as thromboelastograph, and this machine, as you can see, has two chambers, one here and another is here. So we'll know in details about this in the subsequent slides. So thromboelastography, it was actually described by Dr. Helmut Harter at University of Heidelberg in Germany. It was as early as 1948. So this is Dr. Helmut Harter. And the clinical application of this thromboelastography, first it occurred during the Vietnam War, and it was done in attempt to guide transfusions of blood components in injured soldiers. Then in 1980s, it was found to be beneficial in liver transplant patients. And in 1990s, it was demonstrated to be useful in cardiac surgery. So for effective thrombosis, there must be an active balance between three factors like procoagulation factors, anticoagulants, and fibrinolysis. These three factors balance together to attain thrombosis and thrombolysis. So why we need this thromboelastography? Basically, in patients who are on antiplatelet therapy or anticoagulation, if it is inadequate, it can lead to devastating thrombotic conditions and which can cause death. And the conventional test like BT, CT, PT, INR, these things we are having, these are mainly used for screening tool. But the main disadvantage in this case is where the acute major bleeding is present. In some patients, if acute major bleeding is there, so these tests are having long turnaround time. But in this case, thromboelastography can be used. So what basically is this thromboelastography? So it is a non-invasive test that quantitatively measures the ability of whole blood to form a clot. This is done in vitro, and it basically quantifies the dynamic changes of viscoelastic properties of a blood sample during clotting under low shear stress. So basically in this test, we take a blood sample, we apply low shear stress to the sample, and we measure the dynamic changes of the viscoelastic properties of the clot over time. So this is basically thromboelastography. So this is a chart depicting the clotting process in vitro. So you can go through this, you can pause the video and go through this. I'm not going into details, but the main thing is there is a prothrombin which is activated by this factor, prothrombinase, and it is converted to thrombin, which is active form, factor 2A. So this thrombin actually helps conversion of fibrinogen to fibrin, which forms the blood clot. So what happens during the test? So there is, in the machine, there is basically a cup, and below the cup there is a heating component, and above the cup there is a torsion pin which is suspended inside the cup. So we basically take citrated blood in the cup, citrated blood sample inside, and we heat the sample at 37 degrees Celsius. That is the body temperature. The pin is immersed in the blood, and the cup starts oscillating at 4 degree 45 minutes. So the cup starts oscillating. So here is a picture of the apparatus. This is the torsion wire. You can see the torsion pin here. There is a pin, and the pin is immersed in the 0.36 ml of whole blood, which is citrated. And this blood, basically initially it is liquid, right? So when the cup is oscillating, the pin doesn't move. It stays still in the blood, and when the blood starts clotting around the pin, so the blood gets solid and gets hold of the torsion pin. So the torsion pin also moves with the blood clot. So if it is the primary position, so it starts evolving with the blood clot, and the machine, the sensors, they measure this torsion and convert it to data which we can read and interpret as a strength of the clot or some other parameters to interpret the clotting. And as soon as the fibrinolysis starts, the blood clot get dissolved. So then this pin again, the pin again gets stabilized, and the movement of the pin decreases, and we know the fibrinolysis is occurring. So we'll see the graph. So this is a normal thromboelastograph. There are different parts of the graph which we'll discuss in details. So you can see this part. So you can see this part of the graph. This is showing straight line, means the torsion wire is still, it is not moving. So from this point onwards, the torsion wire starts moving and the machine senses the data. So you can see this is the graph where the clot starts forming. This point, the clot starts forming. Then the clot strength is increasing. This is the maximum point of strength of the clot. This is known as the maximum amplitude. And then during the fibrinolysis, this plot, the graph goes down, you can see. So the thing is, again the torsion wire is still in the end. So you can see by this thromboelastography, we can see the whole picture of the clot, whole dynamic changes and the whole evolution of a blood clot inside the body we can see by this thromboelastography. So now let's talk about the parts of the graph. So the first segment is the R time or reaction time. This is this portion. So this portion is basically enzymatic. The normal value for R time is usually 5 to 10 minutes, and this R time signifies the initiation of clot. So what are the factors on which this depends? So R time basically measures the clotting factors are working properly or not, and the anticoagulants. They can also affect the clotting factors, so it can also affect the R time. The next segment is known as K or kinetic segment. So this K segment is from here to here, this point. The normal value of K is 1 to 3 minutes. And what this K signifies is the clot strength. And the main factor that we measure is fibrinogen. So if there is any change in fibrinogen levels, this will impair this K time. Then comes the alpha angle. This alpha angle actually signifies the rate of clot formation by fibrinogen linkage. Normal value is 50 to 70 degrees. So what is this alpha angle? So if we take the point from here, the initiation of K time, we plot a line and a straight line here, a line through the graph, then the angle between these two lines is known as the alpha angle. The normal value is 50 to 70 degrees. And what does it signify? It is the rate of clot formation, how fast the clot is forming. The next parameter that we measure is the maximum amplitude. So this maximum amplitude is the maximum strength of the clot, and the value revolves around 55 to 73 mm. So mostly it depends on the platelets. 80% it depends on the platelets. Baki 20% it depends on the fibrin via GP2B3A, and also depends on factor 2 and 3, which is prothrombin tissue thromboplastin. The next parameter is known as LY30 or lysis after 30 minutes after the MA. So this is MA. After 30 minutes we measure the amplitude, that is the lysis amplitude. So there is another term which is lysis 60, LY60. So these both parameters, this is after 60 minutes measured. So both parameters actually see the clot stability and basically show the fibrinolysis. So the normal value is 0 to 8%. So now let's talk about some common findings in the TEG. So here this graph is showing hemophilia or anticoagulant use. So what we find here, so the R value is increased, you can say the K value is also increased, you can see the angle, the alpha angle is basically decreased from normal. So alpha angle decreased and the maximum amplitude is also decreased. Okay, so this is the basic picture that you see in hemophilia or anticoagulants use. So what management you can give in this case? You can give FFP, you can give cryoprecipitate, and also in some cases if any anticoagulation is used, you can give the antidote like protamine sulfate, etc. The next case can be low platelet function by the thrombocytopenia or thrombocytopathy or use of platelet blockers. So in this case you will see the R is in within normal range, the K is prolonged, and you can see K is prolonged and the MA is decreased. So MA is decreased. So in this case, what management will you give? You can give platelets, of course, and sometimes you can give desmopressin analogs. Okay, we'll discuss about that. The next scenario can be primary fibrinolysis, which occurs in trauma or TPA infusion. So if there is presence of TPA, we'll see the R is normal because clotting factors and anticoagulation status is normal. If you look at the MA continuously decreases. There is a continuous decrease in MA, and LY30 is more than 7.5% and LY60 is more than 15%. So that is indicating primary fibrinolysis. The next scenario can be hypocoagulation, and hypocoagulable state, you can see the R time will be increased, you can see the MA is decreased. In case of hypercoagulative states, you can see R time is really decreased, K is really decreased, and MA and alpha angle, they are really increased. So this is the finding of hypercoagulative states. Now in case of DIC, mostly. In case of DIC, there is hypercoagulation with primary fibrinolysis. This is really a bad prognosis, and in case of DIC, we see that. In DIC stage 1, we see hypercoagulable state with secondary fibrinolysis. In stage 1, we find very less R time, K time is very less, the angle is really increased, and the MA is also increased. So this is hypercoagulable state with secondary fibrinolysis. You can see the fibrinolysis occurring this stage. Okay. And stage 2, which becomes the clotting factor deficiency is there, consumption coagulopathy is going on. So you will see hypocoagulable state. And here you'll find the R getting prolonged, the K is becoming a bit shorter, and the MA is really decreased in this case. So this indicates hypocoagulable state. The prognosis is really bad in this case. So you can take a screenshot if you want. This is the summary of what we just have discussed. So about the management. So it's very easy. We'll remember if the R time is long, so prolonged R time, in this cases, we'll give FFP, we'll reverse the anticoagulants, the specific antidote will be there, like protamine or something. If the K is long or the alpha angle is decreased, then we'll definitely prefer cryoprecipitate. Then if the MA is reduced, we will definitely give platelets, because MA signifies the platelet strength and the number of platelets. And also we can give desmopressin analog like DDAPV. If the LY30 is increased, we'll definitely give tranexamic acid or aminocaproic acids. So this is the basic management from interpretation of TEG. So thank you for watching. Please subscribe to the channel for more content.